Hello friends, in this video we are going to discuss about a case. A middle-aged patient presenting with chest pain and diaphoresis. BP dropped to 80 by 50 following sublingual nitrates. Here the patient presents with sudden onset of chest pain and diaphoresis, that is sweating. So the ECG shown below. Let's now decode the ECG. ECG here shows whenever we get an ECG, we have to check whether it is in sinus rhythm or not. How to check that sinus rhythm? See, here in lead 2, RR interval, every beat RR interval is regular. That is 1, 2, 3, 1, 2, 3 boxes. And here P wave is followed by QRS. P wave is followed by QRS. All P waves looks normal. So this is first thing is it is sinus. It is in sinus rhythm. Next, what is the rate? It's around 100 beats per minute. Then next thing that you have to see is there is C. You have to look carefully. So axis lead 1 is predominantly upward and lead AVF is also predominantly upward, so normal axis. Normal axis. Next intervals you have to see. Intervals, then segments. Interval, first interval is PR interval. See, look at here, PR interval. PR intervals from here to here, almost 1, 2, 3, 4, 5, 6. 6 means 240, almost 240 milliseconds. 240 milliseconds, which is more than 200. So obviously there is prolonged PR interval. Prolonged PR interval. So normal PR interval is 120 to 200 milliseconds. That is 3 to 5 small boxes or one large box. One large square. This is normal. So patient is having prolonged PR interval as well. That suggests AV nodal blockage. And normal axis sinus rhythm 100 beats per minute. Next is segments. See, look at the ST segment, which is elevated in lead to 3 AVF, suggestive of inferior wall Mi, and there is ST depression, reciprocal ST depression in lead AVL as well, and there is ST segment elevation in V1, V2, V3 as well. So suggest of right ventricular involvement. So this is, yes, there is ST elevation in lead to 3 and AVF. This is suggestive of inferior wall Mi. Next, there is ST elevation in V1, 2, 3, that is suggestive of RV infarction. Now, how to say right ventricular is getting infarcted is there is ST elevation in lead 3 is more than lead 2. Look at here. ST elevation, the magnitude of ST elevation is more in lead 3 compared to lead 2. So that suggestive of right ventricular involvement, RV infarction. RV infarction is suggested by ST elevation in lead 3 is more than lead 2. And one more point is ST elevation in V1 and V2. These leads are suggestive of right ventricular infarction. See, ST elevation in V1 and V2 are suggestive of right ventricular infarction. Next, this patient also had ST elevation in right chest leads, that is V4R. Next, so little bit theory about this ECG, this condition. There is this RV infarction complicates inferior for around 40% of the inferior wall mi. And when inferior wall mi is associated with RV infarction in around 40% of cases, and what are the suggestive feature of when right ventricular involvement is, the first suggestive feature is ST elevation in V1. Why V1? Because V1 directly sees right ventricle, and ST elevation in lead 3 more than lead 2. These are the features which are suggestive of right ventricular involvement, and diagnosis can be confirmed by right sided leads. And these patients, one more clinical important feature or one more clinical important thing is, these patients are preload sensitive and may have an exaggerated hypotensive response to nitrates, because these patients are very much preload sensitive. Whenever you give nitrates or drugs which reduces preload, they have an exaggerated hypotensive response. So they have exaggerated hypotensive response to nitrates, as seen in the case, as described in the case itself. Because see, when he was taken sublingual nitrates, his BP was dropped to 80/50. This drop of BP is exaggerated in these patients, in patients with right ventricular infarction. So this is about this condition. Let's catch up in the other video with a different case. Thank you.